Yes, thank you for the kind introduction, and thank you to the organizers of this conference for inviting me out to Singapore. This is my first time out here, and already I'm appreciating how much better the food is, particularly as well as the people compared to our American conferences. I have no conflicts of interest since I serve on the Pneumonia Guideline Committee. We are particularly pure as driven snow or rain these days. So I think in thinking about severe community-acquired pneumonia, it's important to put it in context of other diseases that we spent a lot of time talking about in this conference. Pneumonia is the leading cause of septic shock, the leading organ to be involved, at least in medical intensive care units, and so that the diagnosis and treatment of pneumonia involves all of the things that make up surviving sepsis guidelines and so forth. I won't go into these in the interest of time, but I've listed the main ones on this slide. Pneumonia is also the leading cause of the acute respiratory distress syndrome, and that is defined as bilateral new lung opacities, and then there are different degrees or grades of ARDS based on the PaO2 to FiO2 ratio. And that also, there are specific elements of care of ARDS patients, of careful use of CPAP and BiPAP, perhaps as a temporary measure, using low milliliter per kilogram tidal volumes once you get started with that, and if the patient is not in shock, early furosemide diuresis. But I'm really going to focus primarily on severe pneumonia, even with those contexts that I've just mentioned. So a real issue in pneumonia is that it's fairly complex. And how can a clinician gather all of the data that are needed? How can we make decision-making safe and consistent? And whether computerized clinical decision support might help physicians at the point of care. Now, I'm going to start by discussing the accurate diagnosis of pneumonia, because you can't treat effectively if you don't have the right diagnosis. And this is often passed over by guideline committees, but it's important to recognize that, first of all, pneumonia is a clinical syndrome, and it doesn't have a gold standard except in the 10 or 15% of patients who have positive microbiology. And two studies done in the U.S. showed that of patients admitted to a hospital from the emergency department with a diagnosis of pneumonia, when they were reviewed by an expert panel at the end of that hospitalization, the diagnosis was confirmed in only 62 to 76% of patients. So quite a few patients who are admitted to the hospital with pneumonia end up having some different diagnosis. We've been very interested to use electronic clinical decision support, first of all as an aid to diagnosis and then to help guide treatment. E-pneumonia is what we call it. It's an open loop system that runs in the background in the emergency department. And it starts out by taking 40 different elements and putting them in a probabilistic Bayesian network, meaning that many of those elements you see are actually bidirectional and interactive, and using the chest imaging report from the radiologist, which in our system is available a median of 20 minutes after the film is taken, and that's interpreted by computerized natural language processing. The chief complaint, obviously somebody who's just been shot in the chest is very unlikely to have pneumonia compared to somebody who has an acute cough, the vital signs, the nurse assessment, and labs. And unlike human beings who can only handle 3 to 5 data elements in our decision making, the computer has a weighted, continuous way of looking at all these variables and coming up with a point estimate which can serve as a guide to the clinician. So the way this works is that when the computer finds a patient that it thinks has at least a 40% likelihood of pneumonia, and it actually reviews every patient in the emergency department, there is a P that shows up. It's under the protocol or prot column, about third from the right-hand side. And it starts out as sort of a quiet P, but if the clinician ignores it, it'll get a color, and then finally it'll start flashing. And the clinician then clicks on that P and brings up this screen where you see the point estimate that the computer has calculated, the elements that went into it. So for example, in this patient, you can see that the white blood count is 11.7. The natural language processing finding of the radiograph was positive, and the patient had an abnormal chest exam, according to the nurse. So the physician can either agree or disagree with this diagnosis. If they disagree, we ask them to provide a reason, which we then use in further improvement in our tool. Now, it's generally thought that the clinicians are smarter than the computer, and we give the clinician the freedom without any real review to disregard what the computer says. However, sometimes the computer is right because it's not subject to the same problems and issues that human beings have. And this is a sad case example of a 34-year-old woman who is a mother of 3 who presented with chest pain. And there was a history that she'd fallen from a horse 3 days earlier. And the ED physician really got interested in that history. But if you look separate from that, the temperature was 38.6, heart rate high, white blood count high with a left shift. There wasn't any physical exam findings to go along with the history of trauma. And the chest CT was read as showing patchy bilateral opacities and consistent with lung contusion, but that's because the radiologist got the history of a fall from a horse. So she had a sad outcome. E-pneumonia actually calculated an 85% likelihood that she had it, but the ED physician sent her home with oxycodone, and not very effective for bacteremic pneumococcal pneumonia. She actually had a respiratory arrest at home and ended up with a fatal anoxic brain injury. After you make the diagnosis correctly, the next question is, does the patient need to be in an intensive care unit once you've diagnosed pneumonia? And I'm going to review the 2007 Severe CAP guideline recommendations for defining the need for ICU admission. The first 2 are kind of no-brainers: septic shock, mechanical ventilation. But the minor criteria have been of much more interest to us. You can actually get all of these from the electronic medical record, and there are 9 different elements: multi-lobar disease, a low PF ratio, the CURB, which are from the CURB 65 score, and there are also some sepsis criteria: leukopenia, thrombocytopenia, and hypothermia. And we and several others have validated these criteria, and our e-pneumonia tool suggests that the patient should go to the ICU if they have 3 or more of those minor criteria. And then we also use low PF ratio and refractory septic shock. An electronic tool like this doesn't have to be simplistic or binary. It can use multiple and more complex rules. And so what it does then is shows up with this screen where it makes a recommendation on admission, and then those severe CAP criteria are highlighted in pink, again as a way to facilitate the clinician quickly reviewing information that otherwise they would have to spend a fair bit of time going through a record to find. And then it recommends antibiotics. The standard would be ceftriaxone plus azithromycin. But we have replaced the HCAP criteria with a locally derived score called DRIP, although it's not too much different than a half dozen similar scores that have been developed and validated around the world, and looking for risk for drug-resistant pathogens. And we programmed that into the e-pneumonia tool. E-pneumonia has been running live in 4 of our emergency departments since 2011. And the nice thing about a tool like this is if you decide something's wrong, like HCAP was, you can reprogram it into something different and relatively easily get it going. And these are the 10 different factors. The computer looks for them in the electronic medical record, but that pencil on the side means that the clinician can change what the computer found if the clinician knows something that the computer wasn't able to find. And then for those patients who are admitted to the intensive care unit, the e-pneumonia tool recommends a series of cultures. We've been trying to get away from the routine use of blood cultures in all patients, for example, less sick patients going to the floor. but you get a high yield in the ICU patients. And so you can see the full bore of cultures, urinary antigens, nasal swab. And then if the drip is greater than 4, wherever the patient is, then they get more broad spectrum antibiotics. Now, we published a paper last year with a case series of our results just from doing a simple tracheal aspirate. So a patient intubated within 24 hours. You just do a simple tracheal aspirate and send it off for culture. It cost about $20. And you can see that more than half the time we were able to identify the pathogen. And using this full bore, we were able to get an over 70% pathogen diagnosis in these series of patients. We've also implemented the MRSA nasal swab. It's a kind of a new use of this. So patients who we are worried about methicillin-resistant staph pneumonia, if you get a MRSA nasal swab, since the way people get pneumonia is it's aspirated from the nasopharynx, and it turns out if you have a sensitive test for MRSA that's back in a few hours, if that test is negative, then you can essentially rule out MRSA pneumonia and stop the vancomycin. So it's become routine for us to only give 1 dose of vancomycin in those patients, even where it's suspected that they have MRSA pneumonia. And earlier, actually last year in London at the European Respiratory Society, we looked at the performance of DRIP since we had put it into the electronic pneumonia tool. And this compares the e-pneumonia compared with physicians in the emergency department who, for whatever reason, didn't use the e-pneumonia, because it's always been a voluntary tool, although we're up to about 90% use at this point. And it shows that the number of patients who got an inadequate spectrum was statistically not different between usual care and e-pneumonia using DRIP. But overtreatment went down, so a structured system like this versus HCAP and clinical judgment produced less overuse of antibiotics, and the outcomes were actually favorable as well. So the way we put e-pneumonia in, it has been running continuously. It'll be 6 years next May. It was quite a bit of effort. I know that Jason Fua had done a similar thing using paper forms here in Singapore, but getting the emergency department organized around this, getting the doctors upstairs, the hospital docs, the medical house staff and students, the pulmonary critical care and ID people, and there was just a whole lot of time and effort spent in every which way to get this going. And like I say, we hit 90% use. It really takes a long time to get physicians to think that having a computer help them in medical care is a good idea. One of the things, of course, that helped us was doing studies that were published in peer-reviewed journals. Annals of Emergency Medicine is the leading emergency medicine journal in the world. And here we looked at outcomes of patients who were treated in the 4 emergency departments in the Salt Lake Valley, compared with 2 or 3 hospitals to the north and south, right along the same urban region. And we had a baseline period and then an afterwards period with the e-pneumonia tool. And what this shows is that of patients with community-acquired pneumonia, and there was over 4,000 in this study, after severity adjustment, we had a statistically significant lower mortality at 30 days with CAP. With HCAP, there was no benefit. And I attribute this to the fact that the HCAP logic doesn't work, hasn't worked for anybody, and I viewed it as almost a concurrent control in our study. The reviewers thought differently about it, since our a priori had been that the e-pneumonia would benefit all patients. So in conclusion, severe community-acquired pneumonia should be considered an emergency requiring early recognition and treatment. Jason Fua and I, who I just met Jason at lunchtime here, wrote a review article that made that conclusion based on his work and ours. We've done it through very different pathways. The e-pneumonia tool provides real-time electronic clinical decision support, and we are rolling it out across our system very soon. This is Salt Lake City at the time of the 2002 Winter Olympics, the downtown area. And I will stop there. It looks like I'm right on time, despite my predictions.
Thank you very much.
We have some time for questions, I think.
So what we're going to do is we'll take a couple of questions now, and then if there's time at the end, we'll get all of the speakers up onto the stage for a bit of a panel discussion. Are there any questions for Professor Dean from the floor? I have a question. I mean, one of the things that I find frustrating is duration of antibiotic therapy in hospital, and when it's appropriate to change, to downscale from intravenous therapy to oral therapy. It seems to me that there's a tendency that once a patient gets on intravenous antibiotics, they just seem to continue until someone dreams that they should stop them. Have you got any guidelines for that aspect of management?
Yeah, so we didn't approach that with this tool, which is based in the emergency department, and one of the reasons we didn't is that our system has a relatively short length of stay and a relatively short length of intravenous antibiotics to start with. However, I didn't show you the data from that London presentation. Turns out that if you de-escalate antibiotics earlier, the patients went home sooner and went off of IV antibiotics earlier. So that DRIP score actually helped us do that. We have pharmacists on the floors and in the intensive care unit that are constantly suggesting that if the patient's doing better, that we can de-escalate antibiotics. And overall, that works pretty well. In general, antibiotics produce log kills in the first day or two, and after that, unless you have a protected site of infection, it's not really clear how much more antibiotics you need if you have a immunocompetent host.
Okay, well, if there are no questions from the floor, I'd like to just thank Professor Dean once again.